Thank you, Dan. Morning, everybody. Certainly a distinct honor to be able to introduce Sutchin Patel. His CV is easy to remember. He did his schooling at Brown University and ultimately his urologic residency at Brown. One of our other fine former fellows, Guillaume Perique, recommended we consider Sutchin for the fellowship. And obviously, it's the smartest thing we did. Sutchin was one of our two-year fellows, simply did outstanding work while he was here at UW. And he certainly set a high standard for all our subsequent fellows and also a high standard in many realms. And I would say professionalism, communication, and the history of urology are a few. As you may or may not know, Dr. Patel is highly involved with the AUA in terms of being one of the associate historians, and I think ultimately has become one of the leading authorities in the history of urology. Interestingly, this lecture to some degree was created for visiting rounds that he did at Hopkins, and I think it was Pat Walsh that invited him. And in point of fact, that led us to ask him to consider, also since he is a clinical adjunct faculty member, to have him present a similar type talk to us. So without further ado, Dr. Patel, welcome.
Steve, thank you for that wonderful introduction and the invitation to present today at Grand Rounds. It's great to see so many familiar faces this morning, and I can't wait until we can all meet in person again. As a field, we're fairly fortunate to have the William P. Didusch Museum as a resource and a repository of artifacts and texts that encompass the history of urology. Today, I would like to take you through that history, the history of the museum, and then explore the instrument collection at the museum as it pertains to the development of the cystoscope and the receptoscope. In order to understand the history of the museum, we have to start at the beginning with its founder, William P. Didusch. Bill Didusch was a world-renowned medical artist who studied from 1913 to 1915 under Max Brodel, who was the founder and director of the Department of Arts as Applied to Medicine at the Johns Hopkins School of Medicine, the first full-fledged department of medical art established in the country. At Christmas in 1915, Brodel offered Didusch the opportunity to become staff artist for the newly created Brady Urological Institute under the directorship of Hugh Hampton Young. As a field, we were very lucky that Didusch decided to give this a try, as it would lead to a lifelong close association with urology. In 1949, he was appointed an instructor in urology at Johns Hopkins by William Wallace Scott, and in 1953, he became the executive secretary of the AUA, a position which he held until 1968. I had to add this slide of Bill Didusch's studio. As you can see, Bill has a lot in common maybe with Dr. Hedekin. Bill was a pretty big hunter, as you can see by some of the trophies that he has there, though a few of them were actually donated to him via the AUA. He served as the director of exhibits for the annual convention at the AUA, and in 1946 was appointed the art editor of the Journal of Urology. This was one of the first exhibits that he did with Dr. Young at an AUA meeting. As you can see, a number of his illustrations going over hypospadias, epispadias, and exstrophy. Here you can see Didusch at another of his history exhibits. What Bill Didusch is holding is a hollowed out walking cane used to store a catheter dated to about 1880. And on the table, you'll also see an umbrella that also has a hollowed out core used to house a catheter. The bottom tip of the walking cane can be unscrewed, and the ivory handle piece can also be unscrewed, revealing a small glass cup for lubricant. Here is Dr. Engel, one of the museum's curators, which we'll talk about later, with that same walking cane. This is one of my favorite pictures of Dr. Engel. This was the smirk that he would get on his face when he had a witty remark or a fun historical story to tell you. The history of catheterization is one of the main exhibits at the museum. We unfortunately don't have time to discuss the topic today, maybe a future Grand Rounds topic, but I wanted to show that though a number of different variations of the flexible silver catheter have been described, one such variation involved one of the United States founding fathers, Benjamin Franklin. Franklin was a polymath, an author, printer, statesman, and inventor, and he fashioned a silver-coiled catheter for his brother who suffered from bladder stones. In a letter to his brother on December 8, 1752, Franklin wrote, "Dear brother, reflecting on your desire to have a flexible catheter, a thought struck into my mind on how one might possibly be made. I went immediately to the silversmiths and gave directions for making one, waiting until it might be ready for this post. It is as flexible as one could expect of a thing of the kind, and I imagine will readily comply with the terms of the passage. Yet it has stiffness enough to be protruded." Franklin would later use this catheter likely on himself, remarking that, "When I consider how many terrible diseases the human body is liable to, I comfort myself knowing that only 3 incurable diseases have fallen to my share: the gout, the stone, and old age." Returning to Bill Didusch, he went on to illustrate well over 600 medical articles as well as 18 medical textbooks, beginning with Dr. Young's Practice of Urology, on which he worked for 10 years and was published in 1926. This is a copy of Young's Practice of Urology that belonged to Miss Bertha Trott, who was Dr. Young's secretary. She plays a pretty key role in the early establishment of the AUA, and as Young was on his deathbed, he actually dictated his entire autobiography to her. Here we have Didusch's illustration of Dr. Young's perineal prostatectomy. His surgical approach reduced the mortality of the procedure from 20% to 2%. To facilitate prostatic exposure during the perineal procedure, he developed a prostatic tractor, which was an instrument shaped like a urethral sound. However, the instrument tended to slip out of position when trying to pull the prostate into the operative field. One of the keys to the improvement in the surgery was Dr. Young's construction of a new prostatic tractor, which allowed 2 wings at the beak to be spread open, securing the tractor in place against the prostate, even with increased traction. And this initial prostatic tractor underwent several modifications, essentially becoming longer and with larger wings. You can see 2 of the tractors that we have here that are actually Hugh Hampton Young's tractors at the Didusch Museum. It was during a surprise testimonial dinner in 1971 in his honor that Bill Didusch's comments marked the birth of the William P. Didusch Museum at the AUA. His collection of urological drawings essentially became the basis for the museum. Thus, the collection of Bill Didusch, consisting primarily of his drawings and some of his instruments, were placed at a suite at the AUA headquarters. Display cases were built, cabinets were built, and in January 12, 1972, the museum was opened with an unveiling of the portrait of Bill Didusch, painted by his niece, Ann Didusch Schuler. And standing next to Bill Didusch is Miss Bertha Trott, Hugh Hampton Young's secretary. With the opening of the museum, Bill Didusch became its first curator. Since then, the museum has grown and undergone several renovations. We'll go through some of these throughout the talk. In the library against the far wall of the museum today is Didusch's drawing desk and the last illustration he drew before his death in 1982. At the time of Bill Didusch's death, the AUA had purchased a new building and began extensive restructuring and renovation. This is one of the first AUA headquarters in Baltimore on Charles Street. The museum's contents were put into storage, and while the museum continued to exist there was no curator until the AUA appointed Dr. Herbert Brenler in August of 1985. And the artifacts were brought out, and Brenler's task was to prepare an audit of all the items for review. Brenler began the work, but unfortunately died suddenly in January of 1986. William Wallace Scott was appointed the museum's new curator in 1987. He began the laborious task of cataloging all of the items housed in the museum. It was a fairly tedious and time-consuming process. You can see here that the early museum really was just a collection of Bill Didusch's drawings and a number of instruments, a small number of instruments really in the instrument collection. So a bit roughshod, but the start and the beginning of what would become our museum. The museum was reopened in October of 1989, and Dr. Scott brought history to the AUA meeting through such exhibits as the history of transurethral prostate surgery, the origin of the endoscopic light source, and subsequently the history of regulation of prostatic growth from castration to 5-alpha reductase inhibition. And this is one of the first AUA exhibits that Dr. Scott put together for the annual meeting. Dr. Rainer Engel took over as curator of the museum in 1993. Extensive renovations to the exhibit area were carried out with new display cabinets and an updated story lighting. The storyboards were developed to help tell the story of the development of the cystoscope, the receptoscope, medical illustrations, the history of urethral catheterization, and the history of lithotomy. In 2003, the museum was moved to the new AUA headquarters in Lithicum, Maryland. Under Engel, the central exhibit on the history of the cystoscope was developed, which still stands today. Today, the museum is a collection of instruments, medical illustrations, many of which are Bill Didusch's personal collection, and books. Instruments were Dr. Engel's passion. I was very fortunate enough to spend a few summers with him at the museum, where he took me through the instrument collection, as well as the numerous parts, as well as full instruments that they had in storage. During all of his years as curator, he did not lose his contacts in Europe. He spoke fluent German and had many contacts with the museum and archives of the German Urological Association, first in Dorn and later in Dusseldorf. During his annual trip to Europe, he would attend meetings of the Nation Historical Committee of the EAU, today's History Office. And he was really the ideal conduit between the AUA and the EAU history offices, and he contributed a lot in that collaboration. One can't speak about Dr. Engel without also speaking about his wife, Dorothy. Her support of both Dr. Engel and the museum was tireless. She was always helping around the museum, organizing all the artifacts in the storerooms after Tupper and Dr. Engel placed them in the database and tagged them. Dr. Engel called the cabinets in the storage room Dorothy's drawers. Both Dorothy and Dr. Engel were honored by the AUA board in 2004 with an appreciation award for their work in rebuilding the museum at the new AUA headquarters. Another aspect of the museum that flourished were the annual history exhibits. Dr. Engel always brought a flair to his history presentations. You can see one of these is the presentation on current medicine, which was the use of electricity both in medicine and urology, and chief complaints, which was the history of the ailments of the president. During the early exhibits, the entire Engel family, along with the AUA staff, would help set up the exhibit. You can see it's a fairly laborious task. With industry sponsorship and growth of the exhibit hall, the annual history exhibits took on a life of their own. Under Dr. Engel, history was no longer relegated to dusty books. It became a living, breathing entity. And this was clearly evident in the annual history exhibit. Some of the most successful exhibits under Engel included Civil War Medicine. The 2015 exhibit explored the wounds treated during the war, lessons regarding sanitation from the Crimean War that were applied to the Civil War, the role of battlefield surgeons, the increase in ballistic spinal cord injuries that led to the importance of catheterization for neurogenic bladder. It was a brutal war, and as you can see in the exhibit, it showed. We had a Civil War reenactor who played a battlefield surgeon and performed a host of different surgeries. Some of these exhibits that I'm going to talk about are actually on the website. You can access the actual exhibit, storyboard by storyboard. We'll talk a little bit about the website towards the middle of this presentation. Plagues and Pestilence, the 2008 exhibit, was very relevant today. It was highlighted by the museum last year on its website during the pandemic. It explored the diseases from the Black Plague, cholera, malaria, polio, smallpox, syphilis, the Spanish influenza of 1918, and HIV/AIDS. It was arguably one of the stunning history exhibits, as the exhibit consisted of a large plague ship with panels on its hull documenting each of the various diseases. Skeletons in the Closet, the 2012 exhibit, had the potential to be one of the most controversial exhibits and became one of the most successful exhibits as it chronicled the injustices and indignities that occurred throughout the history of medicine. The exhibit delved into the medical ethics and covered everything from the practice of vivisection, the legacy of Henrietta Lacks, the eugenics movement, the Tuskegee syphilis experiments, Japanese biological warfare, the Nuremberg trials, and J. Marion Sims and the vesicovaginal fistula repair on African slaves. The hope of the exhibit was to shine light on the shadowy corners of our medical past in order to explore the skeletons in our closet. Dr. Engel passed the reins as curator of the museum to Dr. Moran at Chicago at the AUA meeting at that time. And Dr. Moran told me that they had their conversation right under the famous T-Rex skeleton Sue at the Field Museum. Dr. Moran was the last of the full-time curators. With the changing times, the museum has transitioned into having a history committee, which both Dr. Best and myself have the pleasure of serving on, and a guest curator responsible for that year's history exhibit. During the pandemic, the history exhibit was supposed to be battlefield urology. Unfortunately, we never got a chance to exhibit it, though we will eventually have it online. In this upcoming year, God willing, in New Orleans, the exhibit will have as guest curators both Irwin and Sue Goldstein. The title of the exhibit being The Ins and Outs of Sex. In the exhibit Erecting Giants, the 2018 exhibit explored memoirs of greats in the field of medicine. Hugh Hampton Young was the giants covered in the exhibit through his autobiography. Young's autobiography, which, if you have the time to look through and peruse, is actually very fascinating. It's filled with multiple anecdotes. One of my favorite stories describes Young in 1897 walking down the hall in his customarily brisk pace. As he turns the corner, he plows right into Dr. William Halstead, with great force knocking him down. I caught him before he hit the floor and began to apologize profusely. Dr. Halstead, still out of breath, said, "Don't apologize, Young. I was looking for you to tell you that we want you to take charge of the Department of Genitourinary Surgery." I thanked him and said, "That is a great surprise. I know nothing about genitourinary surgery." Whereupon Dr. Halstead replied, "Welch and I said you didn't know anything either, but we believe you could learn." And really at that time, Halstead's comments weren't as if he was bestowing a great responsibility on Young. Urologists were primarily venereal disease doctors, and the bulk of the big oncologic cases that we do today were really done by general surgeons. So this kind of tells you how much Young put into our field and how much he developed the field, really wresting away some of the large oncologic surgeries, from general surgery to make them part of our field. At the center of the exhibit, you'll see this is similar to what Young's operating room looked like, and the ghost of Hugh Hampton Young right in the center. In that exhibit, in the center there, you can see actually Young's operating room table. Early urological tables were cast iron and stationary, bulky and heavy. They didn't allow for much modification. In the workshop where most instrument modifications were built, he developed a table that could be flexed, placed in extreme and reverse Sterndahlberg, and had an X-ray tube attached to it. His first model, described in 1916, was soon followed by modifications. And during the 2018 exhibit, in the center, you can see a video screen. We actually had a video of Hugh Hampton Young performing a perineal prostatectomy on that table. The museum has since evolved with the times. We have a fairly interactive website. In it, you can peruse the exhibits. So we have all the annual meeting exhibits from the past years, as well as the permanent exhibits and collections at the museum. We have the Scope of Urology newsletter, which is biannual. And you can go through the instrument, medical illustrations, and medical library catalog in the collection section. We also have a section on histories, where a number of members and past historians have written small vignettes on people in urology, diagnosis, instruments, urological conditions, and treatment. So a real nice repository of knowledge. If you ever are giving a talk and you need a few extra slides in the beginning to go over the history of whatever you're talking about, I would say either contact Tupper Stevens. I've included her email address there, or see if you can find it on the website. A lot of times you can. And one other nice addition to the museum is we have a virtual tour. So if you click on it, you can actually tour the museum, starting right at the center of the AUA forum, where you walk in and you can see the cystoscope exhibit. You can rotate 360 degrees. At different sections, like for instance, the library, Tupper will have a small video that you can click on where she kind of goes over, the history of the library and what we have there. So still a lot more to be developed there, but I think it's one of the futures in terms of what we expect museums to look like down the line. So transitioning from the history of the museum, the history of the cystoscope exhibit is the central museum exhibit and is seen when one enters the lobby of the AUA headquarters. The beginning of endoscopy started in 1807 with Philip Bozzini, a young German army surgeon frustrated by the difficulties of locating bullets in his patients. The device he created was the Lichtleiter, or light conductor, a sharp skin-covered instrument housing a candle within a metal chimney. A mirror on the inside reflected light from the candle through the attachments into the urethra, the vagina, or pharynx. One looked through a viewing window past the mirror down the funnel into the attachment. The instrument was clumsy, difficult to use, and grew too hot. Bozzini did not live to see the fate of his invention, as he died of typhoid fever shortly after demonstrating it. Despite its impracticality, the Lichtleiter became a catalyst for further experimentation and invention. Short tangent, the original Lichtleiter was kept at the Josephinian Museum in Vienna, which I'll show you a picture of in a second. And it was there for more than 100 years. And it disappeared in 1945 during the occupation of Vienna by Allied forces. 20 years later, in 1965, Dr. Irving Bush from Cook County Hospital in Chicago found the instrument in a cardboard box in the basement of the old headquarters of the American College of Surgeons. Knowing a good deal about the history of urology, he recognized it, took it home, cleaned it, and then promptly displayed it on his TV set for several years. Now, how did he get there? There were a few conflicting stories, but the most likely story is that Sir Eric Riches, a consultant urologist for the British Army, had brought it as a gift, to the American College of Surgeons when he visited in the early 1960s. The Bozzini Lichtleiter was loaned to the AUA to be displayed at a few of its annual meeting history exhibits. And Dr. Reinhold Engel was instrumental, pun intended, in getting it returned to the Josephinian Nitze Leiter Museum. It took about 7 years, but at the centennial meeting of the AUA in 2002, representatives from the American College of Surgeons and the AUA Board of Directors met at the annual history forum to hand over the Lichtleiter to Dr. Manfred Skopek from the International Nitze Leiter Research Society of Endoscopy in Vienna. You can see this is the beautiful Josephinian Museum. And so the original is now housed there, and the Didusch Museum was given a facsimile made in 1989 by the Mercedes-Benz company from Bozzini's original drawings. And thanks for facilitating the historic return of the Lichtleiter. And you can see this is where the Lichtleiter is at the Josephinian. You can kind of tell the difference between the original, which has a fairly flat top, to this, which was the replica built by the Mercedes-Benz company for the Didusch. By the mid-1800s, several new instruments had been created. One was designed by Antoine Desermoh in Paris. The instrument was a long metal channel through which a mirror reflected light from a petroleum-fueled lamp. This instrument had some of the same drawbacks as Bozzini's Lichtleiter, and that became fairly hot when it was used. And he was the first to coin the term endoscope for his invention. Around the same time, a novel instrument model was being developed in the United States. In 1860, Philip Skinner Wales, while doing his postgraduate study at the University of Pennsylvania, created an instrument that contained a metal shaft with a very acute beak, but used an ophthalmologic mirror to reflect light down the channel. One peered through the center hole to look into the bladder. The instrument was created by Horatio Curran, a well-known instrument maker in Philadelphia. The Wales endoscope is fairly rare. There's only one complete set known to be in existence in the world. Dr. Rabinowitz, Dr. Rugendorf, and myself helped donate the funds to help the Didusch acquire the endoscope a few years ago, thus completing the Cystoscope exhibit. In 1878, true endoscopy was born. German urologist Maximilian Nietzsche presented the first working cystoscope, which he had created in collaboration with the Viennese instrument maker Joseph Lieder. Nietzsche grappled with two problems hampering the development of the workable cystoscope. The first was that the light inside the bladder was insufficient, and the second was that the field of vision was too small. So one day while he was cleaning eyepieces of microscopes in his lab, Nietzsche checked and checked the microscope to see if it was clear by looking across at the neighboring church. When it dawned on him, and he realized that the field of view could be enlarged with an optical system, and that the light source had to be placed at the tip of the instrument when it was inserted into the bladder. The same way that in order to light up a room, you have to carry a lamp inside. Thus, using lenses, he created a miniature telescope to magnify the image down the endoscope and illuminated the bladder through its tip using a water-cooled electric platinum filament lamp. The Nitze Leiter cystoscope was a landmark discovery, but it was far from perfect. The instrument's biggest drawback was the tungsten wire, which you can see in the bottom illustration, that was used for lighting. It got very hot and required a complicated water cooling system. The two large horns, which you can see in the top photo, near the eyepiece, were the in and outflow coolants, for the water. And the thinner pegs that you can see were the electrical currents for the bulb illumination. In 1878, Joseph Swan in England and Thomas Edison in the United States almost simultaneously invented the incandescent light bulb. This allowed Dr. Henry Koch and head electrician Charles Preston at the Electrosurgical Institute in Rochester, New York, to create the Minion bulb, a low amperage light bulb that was small enough to fit at the tip of a cystoscope. These bulbs enabled the development of cheaper and easier to use instruments. The only problem were that the bulbs burned out, often at the most inopportune moments, like in the middle of a procedure. In 1890, Reinhold Wappler, a young instrument maker, immigrated to New York from Germany. Soon after arriving, he set up his own company to produce an American cystoscope. One of the first instruments he developed at his new workshop was the Tilden Brown composite cystoscope, an elegant set of instruments with a lens to look straight forward, one at a slight angle and another at a right angle. Again, this is what we essentially use today. The obturators that were previously used to insert the instrument blindly were thus exchanged for the lens system. Meanwhile, in Europe, inventors and clinicians continued to make refinements and improvements in Lieder and Nietzsche's instruments. One such inventor was German physician Leopold Casper, whose catheterizing cystoscope was not easy to use. It employed a complex mirror between the eyepiece and the shaft. But the one big advantage that it did have is that it allowed for ureteral catheterization. By 1900, instruments had been developed to catheterize ureters and irrigate the urethra and bladder. In 1910, the Braunberger cystoscope was created by Leo Berger, a young urologist in Europe who based his design on the Tilden Brown scope. The instrument was produced by the Wappler Electric Company, which later became ACMI. The Braunberger cystoscope remained the workhorse of the American urologists for nearly 6 decades. It was easy to use, enabled catheterization of the ureters, and provided an excellent image. Virtually every urologist owned one of these instruments at that time. It is the most commonly donated item to the museum, such that a refurbished Braunberger cystoscope is given out as the Earl Nation Retroscope Award winner for the best paper and presentation at the annual AUA History Forum. Many of you have heard of the AUA's Gold Cystoscope Award, which both Dr. Nakata and Dr. Abel have won. Ironically, the original name for the Retrospectoscope Award was the Rusty Cystoscope. It should be noted that Dr. Sarah Best also won this award. In the 1960s, urologists used a variety of battery boxes, which you can see in the bottom photo there, to light their instruments. The power to illuminate the bulb was produced by a transformer that was housed in either a large wood-encased apparatus or a small metal-cased device that the urologist wore around his waist. And then the power cord outlet obviously led to the wall. The next revolutionary change to cystoscopes occurred due to advances in optics. When a gastroenterologist in Liverpool was unhappy with the results of his endophotography, he consulted Professor Harold Hopkins, a British physicist who developed what became known as the Hopkins-Rodland system, which he patented in 1959. By replacing small individually spaced lenses with closely packed rod lenses, Hopkins was able to achieve an increase in light levels by 80% with no heat and the achievement of fine detail resolution. It's worth mentioning that Dr. Best published a paper on the work of Hopkins and Dutch physicist Abraham van Heel, who both published their work simultaneously in the same issue of Nature, and really helped bring about modern fiber optics. Hopkins actually initially offered his system to Reinhold Wappler at ACMI, but Wappler said he was happy with what he had at the time. Thus, initially, the industry showed no interest in the new technology. However, a young man just starting a company, Karl Storz, saw promise in the new system and bought the patent. With the Hopkins system, the Storz created endoscopic instruments with tremendously brilliant imaging and superb illumination. It was not long before every cystoscope maker began to create similar lens systems. Fiber optics, the ability of light to follow a curved glass rod, has been known for many years. But it took several decades for physicists and physicians to discover how to harness this ability for clinical use. Early patents for fiber optics were issued to researchers in Britain, Hopkins being one of them, and the United States in the 1920s. The first fiber optic endoscope was developed by Basil Hershkowitz in 1957 for use in gastroenterology. Victor Frey Marshall would perform the first antegrade nephroscopy and ureteroscopy using a fibroscope during an open exploration to visualize the pelvis and the distal ureter in 1960. Improvements in imaging culminated with the development of the charge couple device by George Smith and Willard Boyle in 1969 for electronic video recordings. This served as the basis for our digital scopes today. Max Nietzsche's vision of a cystoscope is encapsulated in his words from 1888. This writing presents only a framework, the complete construction of which will be accomplished over the course of years through the joint work of numerous researchers. We're dealing here with a large new field of work which assuredly harbors untold treasures of knowledge. Now that we've covered the history of the cystoscope, we'll take a very short foray into the development of the receptoscope. In 1874, Enrico Bottini of Italy was the first to employ galvano-cauterization to treat prostatic enlargement. This instrument had a cutting knife that fit the tip for transurethral insertion and a turn handle to cut a V-shaped channel on prostatic tissue. This method was popular for the next 20 years, but it was still performed without vision until Frodenberg made improvements by combining Bottini's galvano-cautery blade with the irrigating cystoscope. The next instrument to impact what eventually became the receptoscope was created by Joseph Grunfeld from Vienna, who was a dermatologist. In 1881, using his snare, he was the first to remove bladder tumors and polyps under direct vision. In 1885, he developed the polypenkneep, the first endoscopic specifically designed to remove tumors from the urethra and the bladder. In 1908, Hugh Hampton Young, having excised a contracted bladder neck stricture suprapubically, was soon faced with dire complications. Obstruction recurred, the patient underwent reoperation, a contracted bladder developed, and the patient subsequently died of uremia. Young then sat down to devise a transurethral instrument to excise such obstructions. In 1909, Dr. Young pioneered the modern punch operation, devising his cold punch to remove prostatic tissue. Initially designed as an instrument for bladder neck contracture and median bars, he soon expanded its use to prostatic obstruction. And here you can see the instrument and how it's used to engage and then core out prostate tissue. Keep in mind, this is a cold punch. So just imagine the bleeding that ensued after the procedure. And as a resident, you'd probably be up all night, the next night, the night after, just manually irrigating clots out of the poor patient's bladder. This type of punch was used on James Buchanan Diamond Jim Brady, who would donate a substantial sum of money to establish the Brady Institute that opened in 1915. And here in the slide, you can see the prostate tissue that was removed from one patient during an operation using the punch. In 1920, John Koch, who had spent some time with Dr. Young at Hopkins, developed an electrified cautery punch with a special syringe for anesthesia. Injecting 10% cocaine into the operative field on direct vision, this newer punch would become a mainstay for the treatment of bladder outlet obstruction due to an obstructing prostate. The cautery did prevent immediate postoperative bleeding, but as we all know, there was often late hemorrhage when slough came away 1 to 2 weeks after the operation. In an effort to further improve his technique, Herman Bumpus at the Mayo Clinic created a cat claw or a cat paw. This instrument was used with a cystoscope and a punch to remove electrified tissue. When I first saw this instrument, it reminded me of the various prostate ablation techniques that were developed over time. Those of us that can remember, there was TUNA, transurethral needle ablation, TUMT, transurethral microwave therapy, and you can draw the corollaries to some of the procedures that we have today. This slide is really just a reminder that not every new invention withstands the test of time, and that throughout history, some concepts are repeated. In 1908, Edwin Beer, convinced that Nietzsche's earlier transurethral treatment of bladder tumors was superior to open surgery, conceived of the idea of using high-frequency electric current through a catheterizing cystoscope to fulgurate bladder tumors. Reinhold Wappler, ever the skeptic, told Beer that the idea would not work, as he believed an air gap was required between the tumor and the electrode. Beer went ahead using a 2-channel Nietzsche cystoscope, one channel for a 6-French copper electrode and the other for irrigation of the bladder, and monopolar current. And he applied this to various points to papillary growth for 15 to 30 seconds at a time, while the bladder was distended with sterile water. Tumor tissue was desiccated at the cautery points, and the patients experienced no more discomfort than during essentially an ordinary cystoscopy. Beer's innovative new method revolutionized the treatment of papillary bladder tumors and would subsequently pave the way for the electroresection methods that we see today. In 1926, Maximilian Stern presented his new Receptoscope. The instrument had a direct vision rack and pinion mechanism. A loop of tungsten wire was used to excise strands of prostate tissue, and the cutting current was capable of operating in water. Though Stern reported no bleeding of any importance, other urologists complained the cutting current produced such shallow coagulation they might as well have used a knife, though they admitted that the instrument worked fairly well. In 1931, Joseph McCarthy built upon Stern's instrument, introducing an oblique lens and a bakelite sheath for insulation. And here you have William Didusch's illustration of the Stern-McCarthy electrotome resecting small bladder tumors. William Bovee was an American scientist and inventor. He's credited with conceptualizing the field of biophysics and with inventing the modern medical device known as the Bovee electrosurgical generator. He first employed his electrosurgical cautery in neurosurgical cases with Harvey Cushing in 1926. And Theodore McCann Davis was an electric engineer that worked on the railroad when he suffered an accident. He thus switched careers and went to medical school to become a physician. In 1931, he added coagulation to cutting current diathermy and created an improved loop, a larger tungsten wire with a greater diameter to bear the higher current. He also introduced a generator with a foot pedal, which we now use today, to switch between cutting and coagulation. In 1945, Jose Iglesias' one-handed leaf spring receptoscope would enter the market and replace many of the Stern-McCarthy-Davis models. Iglesias would also create a continuous irrigation system for the receptoscope. In 1951, Reed Nesbitt wrote, 18 years have elapsed since the receptoscope flashed like a comet across the urological skies, leaving in its wake a trail of sepsis, incontinence, strictures, ruptured bladder, and heartache, as well as partisan argument. But the operation survived. With the advances in endoscopy and the development of the receptoscope, transurethral resection became much safer for patients. This has been a bit of a whirlwind tour through the William B. Didusch Center for Urologic History, as well as the cystoscope and receptoscope exhibits that are the centerpieces for the museum. My hope is that the next time that you perform a cystoscopy or transurethral resection, you can appreciate all the work over the years that has gone towards creating the instrument that you carry in your hands. And then just special thanks to Tupper Stevens for many of the photographs that were used in the presentation.
Wonderful. Thank you so much, Sutchin. I see a lot of claps, both virtual and real claps going on in the little video cubes. We definitely have some time for discussion or questions for Dr. Patel.
Hey again, Sutchin. As expected, that was an amazing talk, and thank you for taking the time to put that together and to share it with us and join us. For everybody else's knowledge, Sutchin really is the guy for urologic history, I think, going forward. So we're all really lucky to know him, and that somebody so dedicated is willing to do that and take that responsibility. I think other things we need to be aware of are that in this day and age of financially strapped organizations, shall we say, and altering priorities, we really need to make a specific decision, a conscious decision, if we want to save our history, because that's an easy thing to cut, the space that this takes, the limited staff that are, salaried to take care of this, including Tupper Stevens, who's one of my absolute favorite people on the planet, is an amazing person and resource as well. So I would encourage you to, think about the importance of history, visit the booth. I think any sort of participation, checking out the website, things like that are tracked by the AUA and help support our interest in keeping this sort of historical information available for all of us. So, sending a message, anything like that would be really appreciated and help keep this alive.
Thanks, Sarah. And I think much of the department has been very interested in history. thank you to Steve for really supporting me in terms of, one of the passions that I really loved, even as a fellow. I think that played a huge role in really helping me along that way. Sarah, as you know, has published extensively on the history of urology. Tracy Downs, when he was here, had written a couple of history papers, and I know a lot of you are also very interested in history. So, it's great to share this, and if we're all able to meet at the AOA, I'd recommend you stop by the history exhibit and the AOA forum. It's fairly interesting, and I think it's very relevant today, and there are a lot of lessons that we can learn and put to use going forward.
Yeah, such a great presentation as always. So my question is, obviously, we brought up the issue of cost. So, the idea of the virtual museum, obviously is quite different. So how do you see it, let's say in the next decade? How are we going to balance the importance of the actual artifacts and the actual booth and the potential, particularly since urology is a worldwide history, and the possibility of a lot of this becoming virtual?
Yeah, I mean, luckily we were forward thinking a couple, 4 or 5 years ago, and we were able, back when we had a larger budget, to begin that transition on the website. So having the virtual, museum tour, Tupper has been lucky in terms of having a lot of volunteers over the past 5 to 10 years on the summer to actually, photograph as well as scan in a lot of documents and instruments. I mean, a very large chunk of our instrument collection is now scanned in. So if you go to that site on the museum, you can almost get lost in all the instruments that are there. But I think that's a really key piece, just because, and this is throughout, people aren't visiting museums at the same clip, for obvious reasons with the pandemic, but I think that trend will probably continue. And so being able to have that forum online, easily accessible, is really important. And the last thing is that we have to make history relevant. So it has to be interesting, it has to be fun, it has to be relevant. We had a number of articles in our Scope of Urology newsletter on the pandemic, some of the history lessons learned, as well as what we went through in the past. And I think that connecting to the past to what we're going through now is a really important piece in order to still have people excited about it and continue to move the museum forward.
Yeah, no, that's great. And I think all of us who give lectures, I always try in the first slide to give some historical perspective. And I think many people do that. More of us should, because it's important.
Great talk, Sutchin. I loved it. Great to see you, man. Congratulations on this part of your career. I hope you're doing well. And I'm pretty sure I've seen some versions of those cystoscopes in room 14 when I was a resident.
Thanks, Chris. It's great seeing you as always. I've seen a couple of your grand round lectures as well. So Chris was chief resident when I was a fellow, which, my gosh, it's been like 10 years or so. So time flies, but it's been good.
Yeah, we have a couple of patients that want to follow up with you, Sutchin. So from that 10 years ago, so I'll keep you posted. Actually, as you presented the Stern-McCarthy, I actually have a Stern-McCarthy set, and that was the scope that Ralph Klayman used to use for the initial look when we would do a PCNL. So he would like to go in first with the Stern-McCarthy because of the soft nose tip, and then we would replace it with, once we were in and comfortable, then we would replace it with a up-to-date nephroscope.
Well, terrific. I know, Sutchin, that was literally just the tip of the iceberg of things that you could be sharing with us about your work in this area and the museum and the the history of all the different little subsets and advances in urology. But that was a terrific presentation, and I know all of us were watching and following along, and certainly look forward to your continued progress in this domain and contributions. So it is 7:45, so we're going to shift gears, and thank you again for your time this morning, Sutchin. Have a great rest of the day. You're welcome to stay on and listen to the residents on the hot seat, the senior and juniors, and have some flashbacks to when you and Dr. Manicus were doing that sort of routine as well. But yeah, we'll shift on gears. Thank you again, Sutchin, and we'll move over to Dr. Krieger, who's running the Unknown Conference this morning.
Thank you, Dan. Thank